Head and neck anatomy number 1. Now, I'm going to follow the college curriculum fairly closely in these head and neck anatomy webinars in terms of what you do need to know, but particularly importantly in terms of what you don't need to know, because there's a great deal of head and neck anatomy that could be learned but which is not necessary for us. And so the college have been very specific about this, and of course the anatomy you need to know has all got clinical relevance. So first of all, let's look at the fascia of the neck. Now this is all layers of what's known as deep fascia. First of all, we've got what's known as the deep investing fascia. This is a thick layer of fascia that lies just underneath the skin, right round the neck. It splits in two areas on each side, one to enclose the sternomastoid and the other to enclose the trapezius muscle at the back. So that's the deep investing fascia. It goes from the jaw at the top, so it starts on the sides of your jaw, and then it goes round the back of the skull, and then it goes right down to the clavicle and to the shoulders, etc. And so it runs right from the head down to the shoulders and the upper chest. So that's the deep investing fascia. Then we've got a fascia layer that goes around the esophagus and the trachea and the thyroid gland. This is it here, and it goes right the way down, in fact, and joins on to the pericardium below, and it goes up to involve the pharynx above. So that's the visceral fascia. Then behind, to either side of that, we've got the carotid sheath. So in the carotid sheath, we've got the jugular, the internal jugular, we've got the common carotid and the internal carotid, and we've got the vagus nerve, three structures on each side enclosed within a fascial layer. And then at the back we've got the prevertebral fascia, and this fascia encloses the spine completely and all the muscles around the spine. Now I'm going to just mention a word or two about the spinal muscles now, because we don't come across it anywhere else in head and neck anatomy. So of course we've got some weak flexors which we can see anterior to the vertebral bodies, and then a number of extensors below. In addition, for flexion, we've got the sternomastoid muscles which flex the neck and extend the head, and we'll be coming to that a little bit later. And of course there are other muscles anteriorly which also have an action in flexing the neck. So most of the muscles that we can see in this image are extensors around the neck and also involved in turning the neck. But we don't need to know the detail of all the various neck muscles. Now you'll notice that between the light green of the visceral deep fascia and the dark green of the prevertebral fascia, there's effectively a space, or at least a potential space, a place where there's a separation between the fascial layers. Now this is an important potential route for the spread of infection right the way down towards the mediastinum, from anywhere higher up from the pharynx and so on. If you also notice that in front of the back of the visceral deep fascia you've got the esophagus, and if you just focus on that space between the flattened purple esophagus and the visceral deep fascia just behind it, again you've got another potential space there, and that's the retropharyngeal space, and we're going to come across that in a few moments. So there's a couple of spaces there that are important. They're both potential spaces. They normally have no structures in them, or very few structures in them, but they can be important in the passage of infection. So those are the main four divisions of the deep fascia of the neck. Let's focus on these other spaces within the head, potential spaces that are all connected to the neck, which are important in the spread of infection. First of all, there's what's known as the parapharyngeal space. So this is higher up, just underneath the skull. So the top of this space, in fact, is the skull. At the bottom of it is the hyoid, and it's described as like an upside down pyramid, with its point at the bottom on the hyoid bone and its base up on the skull above. And it sits to one side of the nasopharynx. It normally has nothing in it, it's just a potential space. But infection can get into this space, particularly from adenoid infection, upper teeth infections, tonsillar infections and so on, and form an abscess in this space like we've got here. So here's a parapharyngeal abscess just sitting in this potential parapharyngeal space. So that's one of these additional spaces that we need to be aware of. Moving on to the retropharyngeal space. So we saw this space between the esophagus and the visceral fascia in the first diagram of the deep fascias of the neck. So if we look at this X-ray, lateral X-ray, we can see that the air space of the larynx and the trachea is pushed massively anteriorly. You normally shouldn't have a space more than half of a vertebral body above the larynx and a whole vertebral body below it. So this is a massively increased space. As you can probably tell from this X-ray, this is in a child, and they are the commonest ones to suffer from retropharyngeal abscesses. So the space is behind the pharyngeal wall and within this visceral fascia, and it does contain a few structures. It contains the retropharyngeal lymph nodes, and that's where the problem comes from, because those lymph nodes can become suppurative from infection spreading from teeth, adenoids and so on, and then cause an abscess which spreads down the neck within the retropharyngeal space. So here we've got a big abscess in this space, and the white line I've just put in is the posterior pharyngeal wall, which has been pushed markedly anteriorly by this abscess. And of course, we don't need to know about the clinical details of this now, but the retropharyngeal abscess can, of course, put the airway in jeopardy and is an emergency that needs intubation, usually in surgery. So that's the retropharyngeal space. Next space I want to focus on is anterior to these. It's just beneath the jaw, and that's the submandibular space. Again, what we're talking about is a potential space, and it's the space between the mylohyoid muscle and the deep investing fascia. So this is a space just below the jaw, but just inside the bone of the mandible, limited on the medial side by the mylohyoid. We're going to look at a picture of the mylohyoid in a moment, and that of course is a bit like an upside down tent, and it's just outside that tent but inside the bone of the mandible. And it again is a site of infection, particularly infection from the teeth. If that infection from the teeth infects this submandibular space but also spreads actually above the mylohyoid, above that tent, but below the tongue in the sublingual space, then the tongue can be elevated, and that's what we mean when we talk about Ludwig's angina. So let's look at this same, so here, just to point out the abscess here in case you haven't spotted it, that's the submandibular space abscess. And if we look laterally at the neck, and here's the mylohyoid, so the mylohyoid runs from the inside of the mandible on each side, meeting in the midline and being attached to the front of the hyoid bone at the back of the muscle. It's a thin diaphragm and helps to hold up the tongue and help maintain the structures beneath the tongue. And so an abscess, here's an abscess sitting just inside the mandible and just outside the mylohyoid in this submandibular space. And if that infection also tracks inside the mylohyoid, then we've got a Ludwig's angina situation with the floor of the mouth being pushed downwards and the tongue being pushed upwards. Okay, so that's the last of the spaces that we need to talk about related to fascia and so on within the neck. Moving on in the curriculum, just to talk about the sternomastoid muscle. So here we can see in this picture the sternomastoid only on the left, and then on the right hand side the sternomastoid and some of the other muscles have been removed to show the deeper layers. So the sternomastoid muscle, there's one on each side of course, and each muscle turns the head towards the opposite side. When both of them work together, they flex the neck, they bend the neck forward, but because they attach to the back of the head, to the mastoid behind the pivot point, they actually extend the head so that the head looks upwards. The sternomastoids are innervated, of course, by the accessory nerve, the 11th nerve, one of the cranial nerves, and we test this in a clinical examination by getting the patient to turn the head to one side and to the other, and putting the hand against the side of the head as a resistance to restrict the rotational movement. So we use it as a clinical neurological assessment. Now I just want to use this same picture here to talk about the triangles of the neck. Now the college curriculum says we should be aware of the triangles, but that we don't need to learn them and their borders and their contents, etc., which is great news, I think, for us. Just to quickly run through them though, you can see that behind the sternomastoid, at its lowest limit, there's a triangle, and then you've got the trapezius muscle. Well, that triangle is known as the posterior triangle of the neck, limited by the sternomastoid in the front and the trapezius at the back. In its base it has the scalene muscles, and it also has some lymph nodes in it, and the omohyoid muscle crosses it. We don't need to know the details of this. But that's the posterior triangle. The anterior triangle is more complex. So the anterior triangle is the space in front of the sternomastoid on each side. And although it looks like you could draw one triangle, in fact, anatomically, it's divided into 4 triangles. 2 of them above the hyoid bone and 2 of them below the hyoid bone. We don't need to know about them, but the ones above are the submental and submandibular triangles, and the ones below are the muscular and the carotid triangles. But we don't need to know all that detail, but just the college says it's worth being aware of the triangles so that you're sure that you know the anatomy within them. Again, looking at the same picture, let's focus on the muscles that we can see within those anterior triangles. So again, the hyoid bone visible in the middle here, and we've got a number of muscles at the top and a number of muscles at the bottom, and they're different on each side because some of them have been removed on what is the patient's right side, the left side of this image. Essentially, there are 4 suprahyoid muscles and 4 infrahyoid muscles. The suprahyoids, going from the hyoid up to the jaw, including, for example, the digastric, the mylohyoid, the genioglossus, those muscles are all involved in lifting the hyoid, lifting the larynx. They're all involved in the swallowing process and in helping to hold the esophagus open. And the college says we don't need to know any more than that. They are also, the digastric, for example, is involved in opening the mouth very wide. The infrahyoids, and again there are 4 of these, we don't need to know the details. They're often referred to as the strap muscles. So the omohyoid is the one that runs from the hyoid down to the shoulder, down to the top of the scapula, but then there are others as well, the strap muscles. And these are involved in the opposite action, depressing the larynx, pulling the larynx down during the swallowing process. So the suprahyoid muscles tend to work earlier in swallowing and the infrahyoids after that. But that's really all that we need to know about these muscles. Moving on to the thyroid gland. So the thyroid gland obviously produces thyroxine, I'm not going to go into the endocrinology of it, and sits in front of the larynx. In fact, it sits in front of the trachea, and there's some details of this that we need to know. First of all, the isthmus of the thyroid, so the thyroid of course has 2 lateral lobes and an isthmus between them. It's just below the cricothyroid membrane. You'll see in the thyroid here there's an upward extension of the thyroid. This pyramidal lobe occasionally is seen in about 1/3 or so of thyroids. So we can see that just above the thyroid we can just make out the space between the thyroid cartilage above and the cricoid cartilage below. And of course that's where the cricothyroid membrane is, and that's where we do a cricothyroidotomy. Above that of course is the thyroid cartilage, and above that the hyoid. The thyroid gland itself is attached to the 2nd and 3rd tracheal rings, and it has a very extensive blood supply. It has an artery on each side that comes off the external carotid, and also it has arteries that come up from the thyrocervical trunk. So it has 4 or 5 in some people arteries. It's got a very rich blood supply. It's very vascular. So trauma to the thyroid causes a lot of bleeding, and similarly if we do a tracheostomy, not done so often these days in emergencies, but tracheostomies involve making a division through the center of the thyroid gland and require careful control of bleeding. We don't need to worry anatomically about the 4 parathyroid glands which sit on the back of the thyroid usually, although the positions are very variable. But we do need to be aware of the landmarks for emergency airways. So I've already mentioned the cricothyroid membrane. So that's palpable on the neck. If you feel what's often known as the Adam's apple, the prominence of the thyroid cartilage, and run your finger down, you'll find a small depression just above the rigid structure of the cricoid cartilage. So that's the location for a cricothyroidotomy. An actual tracheostomy, surgical tracheostomy, is done a little further down than that, counting down the tracheal rings. And it's usually done through the 2nd and 3rd ring, or sometimes through the 3rd and 4th tracheal ring. And of course, the 2nd and 3rd exactly corresponds with the isthmus of the thyroid gland, so it needs to be tied off carefully during dissection. Just to mention the recurrent laryngeal nerve here, so it's not that easy to see the recurrent laryngeal, but the vagus nerves on each side are shown, and you can see on the patient's right the recurrent laryngeal winding back behind the subclavian artery on the right side, and then behind the thyroid gland before entering the larynx and innervating the laryngeal structures, vocal cord, etc. On the other side, the left side, the vagus nerve carries on down to the mediastinum, and then of course the recurrent laryngeal nerve on the left winds back, held by the ligamentum arteriosum, before ascending back up the mediastinum and behind the thyroid gland to the larynx on the left side. The curriculum requires that we know something of the structure of the trachea. So here's on the left, we've just got an outline of the tracheal cartilage rings. So the thyroid cartilage at the top. Then we've got below that the cricoid cartilage, which of course is a complete ring, the only ring that is a complete ring. And then below that, the various tracheal rings. Now, down to the bifurcation, there's a total of about 15 to 20 rings. Of course, these rings are incomplete. They're C-shaped, and at the back, posteriorly, the end of each ring is held to the other end across the gap by muscle known as the trachealis muscle. This is a smooth muscle. It's not skeletal. We haven't got direct voluntary control over it. But whenever we cough, this muscle is activated to constrict the trachea and to speed up the flow of air to improve the function of coughing in shearing mucus off the lining of the trachea, off the tracheal wall. So that's the trachealis muscle. Carrying on with the curriculum focuses on the sympathetic nervous supply to the head and neck. Now, when we've studied the upper limb and we've studied the brachial plexus, we look at the flow of the sympathetic nervous system out of the spine. So it's the sympathetic nerve fibers, of course, descend in the spinal cord, and then they come out at each spinal level from T1 to L2. There's no outflow in the neck. T1 to L2, and on each side there's these rami communicantes which communicate between the spinal nerve and a small ganglion at each level, and those ganglia communicate up and down the spine with each other. Above the T1 level there's no outflow from the cervical cord, but the uppermost ganglion at T1 communicates then further up with 3 ganglia in the neck. The lowest one is called the stellate ganglion, and then there are 2 others, and we'll look at those in a diagram in a moment. So that's the flow of sympathetic innervation up towards the neck and to the head, and it's from there that it gets to the eyes, etc. And all of the sympathetic functions in the head and neck that we're going to come to later are all coming up from the sympathetic chain in the chest and up through the 3 ganglia in the neck. So here's a diagram showing in sort of this light brown colour the cervical sympathetic ganglia. So the yellow nerves behind that are the nerves of the spinal nerves, and we've got these rami communicantes communicating with the cervical, with the chain of ganglia, and then this upward movement of the sympathetic through these 3 cervical sympathetic ganglia, and then into a plexus of nerves wrapped around the arteries, the carotid, the internal carotid, external carotid, and that's the route that they take to their final organ of action. So if we look at a Horner's syndrome, which is a lesion in the sympathetic nervous system, it can occur at various levels. And Horner's syndrome, you might wonder why we labour a Horner's syndrome, because we also talked about this in the upper limb. It's because it comes up in the exams. It's not something that's clinically very common, but it does come up in the exam, so we do need to be aware of it. So if we think about the sites where the sympathetic nervous system could be interrupted, well, let's start up in the cervical sympathetic cord coming down from the brain. We have syringomyelia, which is particularly likely to pick off the sympathetic system descending in the cord. Then if we look at the T1 level, which is the uppermost outflow of the sympathetic supply in the neck, that can be involved in the lower type of brachial plexus injuries. We talked about Klumpke's type palsy occurring sometimes at birth when the arms are pulled on, and classically in adulthood in a fall when someone grabs a branch or something to try and break their fall, and the plexus is pulled upwards. And so that can be one source of a Horner's syndrome. Beyond T1, as the sympathetic moves towards the ganglia, there can be an interruption because of penetrating trauma. There can be an interruption because of the spread of a tumour within the apex of the lung. That's what's known as a Pancoast tumour. And then as it runs up in the wall of the artery, if there's an aneurysm, a significant aneurysm within the carotid artery, that can interrupt the sympathetic supply. So there's a series of places where a Horner's syndrome can arise. Okay, let's moving on from that to the root of the neck. So the curriculum identifies a series of structures in the root of the neck that we need to be aware of. So this diagram here shows just a few structures. So we've got the first rib on each side attaching to the sternum, the manubrium at the front, and then we've got a few vertebrae from the neck, and the muscle in purple is scalenus anterior. The college helpfully tell us that we don't need to know about the detail of scalenus medius and scalenus posterior. We only need to know about scalenus anterior. Well, scalenus anterior arises from the 3rd to 6th vertebral bodies and descends down to insert on the first rib. And it has 2 important useful anatomical functions or features. One is that the insertion point on the first rib separates the artery from the vein, the main vessels going to the arm. So the subclavian artery goes behind it and the subclavian vein is in front of it, of its insertion on the first rib. And then over the front of the scalenus anterior, the phrenic nerve runs down from its origin within the brachial plexus, within the cervical plexus higher up, and it runs down before turning to become more medial in the mediastinum, and then of course it runs over the pericardium, and we'll meet that in thoracic anatomy. The other structures that I've labelled here are the thoracic duct in green, just worth being aware of that. About the only time that's significant to us in emergency medicine is when we put in a subclavian line. We don't do that as often now that with the use of ultrasound we tend to go for internal jugulars. But if we put a subclavian line in on the left, there is a risk of damage to the thoracic duct. If the thoracic duct is damaged, it's a low pressure system, but you can have lymph leaking into the mediastinum, what's known as a chylothorax. And it can be a very difficult thing to repair. So that's the thoracic duct, and that's why we always prefer right subclavian vein cannulation to left if possible. We can also see how the subclavian vein runs over the top of the first rib, and of course the clavicle isn't shown here, but the clavicle would lie superior to the vein, and of course we would access the subclavian vein from its position underneath the clavicle. And where the vein passes between the clavicle above and the first rib below, it's supported and held by those structures, and one of the values of that is it prevents the vein collapsing completely in underfilled patients who are hypovolemic, and so it's one of the reasons why it's a good vein to aim at if you're needing to get emergency venous access. Okay, so that's the main structures in the root of the neck. You can also see the light grey here denotes the domes of the lungs, the tops of the domes of the lungs, and the subclavian artery runs over the top of the lungs before passing behind scalenus anterior and into the arm. The curriculum mentions a particular lymph node which is found in the neck, just the root of the neck, which is known as the jugulo-omohyoid lymph node. So I've indicated its approximate position here. It's very close to what's known as the central tendon of the omohyoid. Omohyoid has a tendon in its center where it runs behind the sternocleidomastoid. And the node there is important because it may be involved in tongue cancer. Tongue cancer, classically, when it spreads to that node. So if that node is palpable, it may be an indication of tongue cancer. And of course, some tongue cancers can be quite posterior and difficult to see clinically when examining a patient. So it's one thing to look out for. The final subject I'm going to cover is on facial muscles. Now, I've just drawn in a few of the facial muscles here. The facial muscles, of course, are quite complicated. They're all innervated by the facial nerve, the seventh nerve, and there's a series of them that we need to be aware of. So the college has reduced what we need to know down to a few main groups. So up at the top here, we've got frontalis. Now that's actually part of a muscle known as occipitofrontalis, which has a big aponeurosis that runs between the anterior and the posterior bellies of the muscle. And that's the muscle that we use when we're raising our eyebrows, wrinkling the forehead. And that's, of course, innervated by part of the seventh nerve, and we'll come into the detail of that later. The orbicularis oculi is the muscle around the eye, and it's a classic sphincter. It's attached to the bone medially, and it's what we clench when we screw up our eyes and close our eyes very tightly. It's the orbicularis oculi. When we come down to the muscles around the mouth, we've got a much more complex system. Now, orbicularis oris was originally thought of as a sphincter, much like orbicularis oculi, just running around the mouth, that we contract all of it and close the mouth. But in fact, it's much, much more complex than that, and there are a number of components to orbicularis oris. And it's surrounded also by a series of different muscles that all contribute to facial expression, to smiling, to frowning, to lifting the upper lip, moving the corners of the lip, etc. And there's a number of these, including zygomaticus major, risorius, buccinator, and depressors and elevators of the angles of the mouth. And we don't need to know the detail of those muscles, apart from a few details that I'm just going to cover now. First of all, if you look at the angle of the mouth, you can see that a number of muscles converge on that point. And that point is known as modiolus, M-O-D-I-O-L-U-S. Modiolus is this convergence of muscles at one point at the corner of the mouth, where the muscles are then held to each other by a series of fibrous structures, fibrous bands, so that the whole area can be moved in different directions by the various different muscles. And a number of muscles contribute to that: orbicularis oris, buccinator, risorius, and the depressors and elevators of the angle of the mouth all contribute to modiolus. And of course, injuries to that can have quite a profound effect on facial appearance. One of the muscles that contributes to it is buccinator. Now, buccinator runs more or less horizontally from the corner of the mouth on each side before attaching to the skeleton, attaching to the zygoma at the back. And buccinator is important in a number of ways. First of all, it's what keeps the food inside your mouth. So when we're chewing, the buccinator muscle contracts and holds the contents of the mouth inside the teeth, or between the teeth, stops it pooling into the cheeks. And of course, that's one of the problems for people with a facial palsy. They don't have this buccinator function, and food collects in the cheeks and dribbles out and so on. And so buccinator is important in holding the food in. It's also important in infants during breastfeeding. It's part of the system for creating a negative pressure within the mouth and creating suction. So the buccinator is an important muscle in that sense. First of all, let's look at the facial nerve. Now, the facial nerve, it passes through the middle ear, and we'll talk a little bit more about that later, before emerging at the stylomastoid foramen, between the styloid and the mastoid, and winding round and passing through the parotid gland before branching into its 5 branches. One branch, the temporal branch, goes upwards and provides the frontalis muscle. One branch goes forward across the zygoma and is involved in the orbicularis oculi. One branch goes across to the upper lip and involved in the orbicularis oris and other muscles around the mouth. One branch goes down to the lower jaw, the marginal mandibular branch, and one branch goes down to the neck and innervates platysma. So those are the branches, and as we know, facial nerve, these branches are all motor branches, and they're all to the muscles of facial expression. So that's the facial nerve and its branches, and we'll be touching on some of these again in different ways. Moving on then, so that's the 7th nerve. Let's go to the 5th nerve, the trigeminal nerve. Now this has a large ganglion just inside the skull, and through that into the ganglion come a sensory root and a motor root. Of course, the motor root is to all the muscles to do with mastication, to do with movement of the jaw and chewing and eating and so on. And then those go into the ganglion, the sensory and the motor root. Then out of the ganglion come 3 branches. The ophthalmic division, which goes into the back of the orbit. The maxillary division, which runs forward within the skull and near to the nose, and we'll be meeting more about that later. And then the mandibular division, which goes down towards the lower jaw. So these are the 3 main divisions of the trigeminal nerve, and we're going to be meeting these again in various ways as we go on. First of all, let's look at how the trigeminal nerve provides sensation to the skin of the head. Now, the back of the head is innervated more directly from cervical nerves, and we'll come to those in a moment. But the front of the face up to the top of the head is provided by the trigeminal nerve, and it has its 3 divisions, each of which has a series of branches. And the college curriculum says that we need to know these branches, so that I'm only listing these because the college says that we need to know this, and because several of these are the focus for nerve blocks, so that we can use a local anesthetic and innervate a particular area. So let's start with the ophthalmic division, and we need to know 5 branches. So first of all, the supratrochlear. So this is fairly close to the midline, just going up from the orbit. A tiny bit lateral to it, you've got the supraorbital branch. Again, an area that's where you can usefully anesthetize before doing suturing, etc. on the scalp. More laterally, from the top of the orbit, you've got the lacrimal branch. And then you've got 2 branches on the nose, the infratrochlear, and then a branch called the anterior ethmoidal. Now, the anterior ethmoidal has already provided a lot of the sensation inside the nose before the very final twigs of it come out over the tip of the nose. So those are the 5 branches, cutaneous branches of the trigeminal ophthalmic division that we need to know. Of course, we can use blocks on these, and it's also worth being aware that this is also the distribution of ophthalmic herpes zoster, shingles affecting this particular division of the trigeminal. And of course, as you can see here, the eye is involved. And so one of the guides to is the rash shingles is if it goes down to the tip of the nose, it's ophthalmic. You've got ophthalmic shingles, and therefore you've got a significant risk of the eye being involved. So that's the ophthalmic division. If we come down to the maxillary division, the first branch of this at the top of the maxillary area is the zygomatico-temporal. The next one, a small branch just below that, is the zygomatico-facial. And then finally, the most important perhaps for us clinically, is the infraorbital branch, which comes out on the cheek and spreads down and provides sensation for the upper lip, the side of the nose and the cheek area. And that's a common nerve to be blocked, particularly for repairs of the upper lip. So that's the infraorbital nerve. The superior alveolar nerve, that's the nerve to the upper teeth, comes off just before the infraorbital, just within the bone, and then passes down in the bone to involve the upper teeth, to innervate the upper teeth. And as a result, when you use an infraorbital nerve block and put local around the infraorbital foramen, some of it will seep into the infraorbital foramen, and sometimes the superior alveolar nerve is blocked as well, and you get numb teeth, you get numbness of the teeth. And of course you can specifically aim to do that if it's the teeth you're primarily interested in blocking. So those are the maxillary nerve cutaneous branches. Now I'm only focusing on cutaneous branches here. There are other branches to do with internal structures which we'll come across later. Finally, let's look at the third division, the most inferior division, the mandibular division. And this has a large branch that goes just in front of the ear here, the auriculotemporal branch. And then it has two other branches, a small one over the cheek called the buccal branch, and then finally a branch that comes out at the front of the mandible, the mental nerve. And that's the end of a larger branch called the inferior alveolar nerve, and it comes out through the little mental foramen and provides sensation over the end of the chin, etc. So there we have it, 5 from the ophthalmic division, 3 each from the mandibular and the maxillary. What about arteries in the face? So if we look at the external carotid artery, which has a series of branches, we just need to really know about 2 of these. First of all, the facial artery. Now this winds around underneath the mandible and can be felt. The pulse can actually be felt as it goes around the edge of the mandible, and then it travels upwards. It passes just lateral to the mouth, so it passes through the cheek just lateral to the mouth, and then it crosses across the cheek and up to end really close to the medial border of the eye. It has a tortuous path, and of course the whole face is very vascular. The other branch that we need to be aware of is the superficial temporal artery. Now this is effectively a continuation of the external carotid artery. So the external carotid runs straight up as the superficial temporal runs just in front of the ear, and so you can actually feel it by palpating over the zygomatic arch just in front of your ear. You can feel the pulsation there. And then it has terminal branches in the scalp, and we'll come to scalp circulation in a moment. But one of the branches runs forward across the temple and can be felt there, so you can feel a pulse in the side of the temple. And that's often an area that's involved with giant cell arteritis, temporal arteritis. So it's a good accessible area for arterial biopsy in diagnosing giant cell arteritis. So those are the arteries in the face. The veins in the face are very variable, and we don't need to worry too much about the details, other than being aware that there are connections between the facial vein and the cavernous sinus. Now, of course, the cavernous sinus receives blood draining from a range of areas, from intracranial and other areas. And it also has the ophthalmic veins draining into it backwards from within the orbit. Now the facial vein has connections to ophthalmic vein which connect into the cavernous sinus. And the significance of this is that infection within the central area of the face, so that's the cheeks, the nose, around that area, the inner canthus of the eyes, that if you have infection in that area, particularly if it's severe sepsis, then infection can spread in the veins backwards into the cavernous sinus and cause thrombosis. So thrombosis can spread in that area, and if you have a cavernous sinus thrombosis, that has got a number of serious implications in terms of venous drainage and engorgement and so on. So the curriculum requires us to understand something about these connections between the facial vein and the cavernous sinus. I mentioned the circulation in the scalp because whenever we have to deal with wounds in the scalp, we're aware of how vigorously the scalp can bleed. First of all, let's just remind ourselves of the layers in the scalp. Now, helpfully, the word scalp has 5 letters, and each of those can be viewed as relating to a particular area, a particular layer. So here I've got a pink layer, which is the skin. C is connective tissue. Now, we're going to talk a bit more about that because the connective tissue layer is very important in the vascular supply. Then below that, we've got the aponeurosis. So this is like a very large, flat tendon that runs over the top of the scalp from front to back. Beneath that, I've shown in blue here an area of loose connective tissue, so that corresponds with the L of scalp, and then P is the periosteum, so that's or it's also known as the pericranium, the final layer, fibrous layer, just adhering to the bone, against the bone. Now, if we go up to the second layer, the connective tissue layer, this has a particular structure in the scalp with a lot of fibrous septa in it. And the blood vessels in this layer are adherent to this fibrous structure, which stops them from contracting down in the normal way if a vessel is opened, if it's cut. As a result, therefore, scalp wounds do not undergo good hemostasis naturally. They bleed a lot because it takes a while for these vessels to all contract adequately and stop the bleeding. So that's the significance of this connective tissue layer, that the arterial supply runs in, these arteries running off from the facial artery, etc. If we then look at the aponeurosis, now of course the aponeurosis stretches right across the head. We're going to look at that a bit more when we look at the frontalis muscle, and that is able to glide quite freely. It's able to move quite a distance over the top of the scalp, and it does that because the layer below it, the blue layer, the loose connective tissue, is exactly that. It's loose, and it allows quite a degree of freedom of movement for the aponeurosis above it. So that's the layers of the scalp that we need to be aware of. And if we look at this in another diagram, now I know this is quite a very simplified diagram here, but I've shown the aponeurosis again as a grey layer running right over the top of the head from the back to the front. Now the two parts of the occipitofrontalis muscle attach onto this layer. There's a part at the back, the occipital, and a part at the front, the frontalis. Each of these are innervated by the facial nerve because it's a muscle of facial expression. And when you contract the occipital part of this, it's attached to the bone around the back of the head, which anchors it. So the occipital part, when it contracts, pulls the whole aponeurosis backwards. Now the frontal part, the frontalis part of this, doesn't attach to bone. If it did, effectively the contraction wouldn't achieve anything because the aponeurosis wouldn't be able to move anywhere. But what the frontalis muscle does is it attaches to the skin and the face and the fascia in the face. So as a result of that, when you contract your occipitofrontalis, what you do is you pull your whole aponeurosis backwards, you wrinkle your forehead, you lift your eyebrows, etc. So it's part of facial expression. One of the clinical significances of this is to do with bleeding under the aponeurosis and the way in which blood tracks after a hematoma forms. Now, this aponeurosis is fairly adherent laterally to the temporal line, and it then becomes the temporal fascia. We don't need to go into the detail of this, but essentially blood under the aponeurosis can't really get out sideways. It can't get out posteriorly because the muscle is attached to bone there, but it can come out anteriorly where the aponeurosis and the muscle are not actually adhering to bone. So what happens is, if you have an injury to the top of the head and you get bleeding under the aponeurosis, the blood, as it starts to break down, it travels forward and appears around the eyes and gives the patient black eyes, and the patient thinks, why have I got bruising around my eyes? The injury was on the top of my head. Well, that's the anatomical explanation for that. Okay, well, we talked about the sensation in the face that's related to the trigeminal nerve. What about the sensation in the back of the head, the part that's not innervated by the trigeminal nerve? Well, here it's shown in blue and in purple. And what this relates to is the divisions, the posterior and anterior divisions of the cervical nerves. So to put that simply, if we remember that at each level, each spinal level, the roots combine and then they separate again into anterior and posterior rami. And normally we don't think too much about the posterior rami. They provide motor and sensory supply all the way down the spine. And in the case of the back of the head, two branches come off posterior rami from C2 and C3 and provide sensation at the back of the scalp. The ventral rami provide one branch which does the purple area. So let's look at the actual nerves. The posterior divisions, the posterior rami is the greater occipital nerve, which goes up over the back of the scalp to the vertex. It's a larger nerve. And then the lesser occipital nerve that's a bit further around towards the ear. And both of these, in particular the greater occipital nerve, can be anaesthetized with local anesthetic to give an area, to give a field block over the top of the head. The ventral rami, as I say, the ventral divisions, the greater auricular nerve comes off what's known as the cervical plexus, which is a complex of the various spinal nerves within the neck, and this produces the greater auricular nerve, which passes up behind the ear and provides some of the sensation to the ear. When we look at the actual sensory supply of the external ear, unfortunately it's quite a complicated subject, and there are 4 different nerves that can provide sensation to the ear. First of all, the auriculotemporal, so that's part of the mandibular branch of the trigeminal, that's the auriculotemporal. Then the lesser occipital, so that's from the spinal posterior rami. Then we've got the greater auricular, which is from the ventral rami. And then finally, the ear canal itself has its sensory supply from the vagus and to some extent from the glossopharyngeal. And so the glossopharyngeal is inside the tympanic membrane, but the distribution of vagus and glossopharyngeal in the ear is similar. So it's a complex subject, the sensation of the external ear, reflecting the embryology, the development of the ear. Okay, moving to another subject, the curriculum requires us to know about the temporal fossa. So here we are looking at the side of a skull, and the temporal fossa is this area bounded by the yellow line here. So it's the area in which the temporalis muscle occupies it. You can feel it on the side of your head if you clench your teeth. And it's got a fairly complex set of bony components to it. So we've got the zygomatic arch here in purple and blue, the posterior part arising from the temporal bone and the anterior part coming from the zygomatic bone. And then if we look inside the fossa itself, we can see part of the sphenoid bone. Now, I haven't shown them in colour, but above the sphenoid bone we've got the frontal, and then behind it we've got the parietal bones from the skull. So those are the bones that are involved in the temporal fossa. Not sure it's clinically all that important, but we are expected to know it. So what about the anatomy in that area? Well, I've shown here in the temporalis muscle. It's a large muscle, goes quite a long way up the side of the head before inserting on its tendon, inserts on the mandible, and of course it's one of the two muscles each side involved in clenching the teeth, closing the teeth tightly. The other structures that run over the temporal fossa, we've got the superficial temporal artery. We've already met this. It's the terminal branch of the external carotid and runs up before dividing into branches for the scalp. And then there's two nerves we've got labelled here. The auriculotemporal, we've already met this. It's part of the mandibular, part of the trigeminal, runs just in front of the ear, provides some of the sensation for the external ear, and the rest of that mandibular section of the dermatome. And then we've got here a motor nerve, the temporal branch of the facial that we talked about earlier, that supplies the temporalis muscle. So those are some structures around the temporal fossa that can be injured on a blow on the side of the head, particularly if they get trapped against the zygomatic arch. So that's the temporal fossa. Below the zygomatic arch, we've got a couple of structures that we just need to talk about, the masseter and the parotid. So first of all, the masseter muscle here is a powerful muscle involved in clenching the teeth, closing the jaw. So it arises from the zygomatic arch above and then inserts on the edge of the mandible below, around the angle of the mandible, and it's a powerful closure of the jaw. Of course, like the temporalis and also the pterygoids that we'll meet in a moment, it's innervated by the motor part of the trigeminal nerve, the motor part of the fifth nerve. So that's the masseter. And then the other structure that I've put in here is the parotid gland, the largest of the three salivary glands, the main three salivary glands on each side. And of course it has a duct which moves anteriorly from the parotid gland, winds around the front of the masseter, and then opens into the mouth, into the buccal mucosa, opposite the upper teeth. In fact, it's opposite the second molar tooth. And that's the parotid gland. And the parotid is innervated for its secretion. It's a parasympathetic innervation. We also have parasympathetic innervation for the other salivary glands. We'll meet them shortly. But for the parotid, its innervation is through the glossopharyngeal nerve, and the ganglion for this parasympathetic has the local ganglion is the otic ganglion. So that's the innervation that provides sort of secretomotor innervation to the parotid gland. The remaining muscles of mastication, jaw movements, are the pterygoid muscles. And to look at those, this diagram here, you have to imagine yourself looking at the mandible from inside. So this is as if you took the skull away, took the back of the skull away, and looked at the mandible from the inside. And the two pterygoid muscles on each side, they're actually quite complex structures with different components to them, but they attach to the pterygoid plates. We don't need to know the detail of where they attach. The medial pterygoid, which is the larger of the two on each side, comes from the inside of the jaw and attaches to between the pterygoid plates. And if you imagine when that contracts, it moves the jaw sideways. And so you've got one each side, and you use them in chewing. In chewing, they move the jaw from side to side. The lateral pterygoid attaches close to the actual joint itself, to the temporomandibular joint. And when that contracts, what it does is it actually pulls the jaw joint forward. And so it protrudes the jaw. If you stick your jaw out, if you jut your chin forward, that's done by your lateral pterygoids. And so that's how you move the jaw forward, but that's also a component of the mechanism of jaw opening. Jaw opening is, of course, a complex movement. The TMJ is not just a rotation, it's also a forward movement of the joint, and that's the forward component of that is the lateral pterygoids. Again, they're innervated by the trigeminal nerve through its motor component. Just to focus for a moment on the mandibular branch of the trigeminal. We've talked a lot about the trigeminal. It has its ganglion inside the skull and then its 3 divisions which pass out through different holes in the skull. The ophthalmic division goes out through the orbital fissure, the upper orbital fissure. The maxillary goes out through the foramen rotundum, and the mandibular leaves the skull in the foramen ovale. It then gives off its buccal branch, but we're just going to focus here on the lingual nerve and the inferior alveolar nerve. So the lingual nerve is the nerve to the tongue, and the inferior alveolar nerve enters the mandible and travels down and provides sensation to the inferior teeth. We've already met the superior alveolar nerve just inside the infraorbital foramen, but here we have the inferior alveolar nerve for the lower teeth. And then of course finally the inferior alveolar nerve comes out through the mental foramen and provides sensation over the chin. This is a good point at which to mention the chorda tympani. Now the chorda tympani is a nerve that travels with the facial nerve into the internal acoustic meatus and then in the middle ear before leaving the ear and joining the lingual nerve, the lingual part of the mandibular nerve. Its primary function is to provide special sensation. So it provides the taste sensation from the anterior 2/3 of the tongue. We'll talk about the back of the tongue shortly, but the chorda tympani is taste sensation, not somatic sensation, touch, heat, etc. Those all come from the normal somatic sensation within the lingual nerve. But the chorda tympani does the taste for the front of the tongue. It also provides the parasympathetic fibers for the submandibular and sublingual salivary glands. So the sublingual just in front of the mouth, floor of the mouth, beneath the tongue, and of course the submandibular, which is just at the sides of your jaw and then has a long duct that runs through the floor of the mouth before opening just beneath the tongue, and we'll meet them in a later webinar. Okay, now let's move on to some other nerves. The glossopharyngeal nerve is the ninth cranial nerve, leaves very close to the vagus and to the accessory. So the 9, 10 and 11 all leave the brainstem very close together, and they all pass through the jugular foramen into space below the skull. So the glossopharyngeal actually winds around the side of the pharynx and heads towards the tongue and gives off a series of branches. It's a complex nerve, the glossopharyngeal, because it has at least 4 different functions to it. It's got a small amount of motor function, which is to one of the muscles involved in swallowing. We don't need to know the detail of it, but it's got a small amount of normal motor function. It's got parasympathetic function to the parotid glands. We've already met this. Then in the sensation, it's got special sensation, visceral sensation, from the carotid body and the carotid sinus. So the carotid body is to do with cardiovascular system. So the carotid body is that bulge at the bottom of the carotid, which is distended by increasing blood pressure and provides a sensory input as to the level of blood pressure. And next to it, that's the carotid sinus. So the carotid sinus sits at the bottom of the carotid and is distended by blood pressure, increases, and provides a sensory input about blood pressure. The carotid body is right next to it and is a small area of specialized sensory cells that can detect oxygen level, and also to some extent carbon dioxide as well. So you've got these 2 special sensations, one to do with the cardiovascular system, one to do with the respiratory system, both travelling in afference to the brain and the glossopharyngeal nerve. You've also got ordinary general sensation travelling in the glossopharyngeal nerve as well. So you've got parts of the ear. We've already talked about how the external ear has the vagal innervation, but as you get inside the tympanic membrane, the cavity of the middle ear is glossopharyngeal primarily, although they both overlap to some extent. The upper pharynx is glossopharyngeal nerve innervated. The posterior third of the tongue is also receives its sensation in the glossopharyngeal nerve, and taste from the posterior third of the tongue travels in the glossopharyngeal nerve also. I'm going to come to the gag reflex in a moment, and we'll talk about how we test glossopharyngeal nerve function. But let's just repeat what we've said about the tongue. So the tongue has both ordinary somatic sensation. The tongue can feel a touch. If you touch your teeth, you can feel them very clearly. It can also feel temperature. If you take a hot food, it can feel temperature. So those are both somatic sensations. The anterior 2/3 go in the trigeminal nerve through the lingual branch of the mandibular part, and the posterior third is the glossopharyngeal. So that's somatic sensation. Then taste, a special sensation. The anterior 2/3 are the chorda tympani, which travel partly in the mandibular nerve but ultimately have come from the facial nerve. And then the posterior third taste is also in the glossopharyngeal. So the tongue, the two types of sensation in the tongue are quite complicated. So that's the glossopharyngeal nerve. Let's move on to the vagus. Vagus, the 10th nerve, also comes out through the jugular foramen right next to the glossopharyngeal. It then enters the carotid sheath, and of course from there it goes right the way down the body with numerous branches. Of course, there's the recurrent laryngeal, which we've met elsewhere, with its right branch hooking around the right subclavian and its left branch around the ligamentum arteriosum. And then there are all these branches of the vagus to the stomach and to the small intestine and the large intestine. And so it's got an extensive network. The vagus also goes to the lungs and so on. And all parasympathetic supply between the neck and the colon throughout the body, between those upper and lower limits, is in the vagus nerve. It's a mixed nerve, so what other sensations does it have? Well, it has motor fibers in it, so it's responsible, of course, for the larynx, moving the vocal cords. All of the laryngeal movements come from the vagus nerve. And it also has motor fibers to the constrictors of the pharynx and a number of the pharyngeal muscles. And when we test the gag reflex, so if we touch the upper pharynx with a tongue depressor, for example, the glossopharyngeal will provide the afferent, the sensory pathway, and then the efferent pathway will come in the vagus, and so that will lift the palate, the soft palate, and also cause other movements of the pharynx as part of the gag reflex. Interestingly, it's a crossed system, so whichever side of the pharynx you stimulate, the whole thing should go into a gag reflex. So that's the motor. It's also got some special sensation. We talked about how the glossopharyngeal nerve has special sensation from the carotid body, the sensation of blood gases, PO2, PCO2. Well, the vagus also has a similar function to the sensors in the aortic arch. So these are your peripheral chemoreceptors, part of your respiratory system, and they're provided by the vagus, the aortic arch. The vagus also has special sensory afferents from the lungs, and this is where your Herring-Breuer reflex and your J receptors, all the afferents travel in the vagus nerve to the brain. And finally, as if that's not enough, finally you've got ordinary general sensation, so somatic sensation from parts of the ear, pharynx, and all of the larynx, all of the sensory afferents in the larynx travel in the vagus nerve. So it has a wide range of functions. The final nerve I'm going to talk about is the accessory nerve. The accessory small nerve also comes out in the jugular foramen along with 9th and 10th, glossopharyngeal and vagus. Now it has some roots directly from the brain stem and some from the upper part of the spine, and so rather unusually it has these roots that arise from the spine, which then re-enter the skull. It would go up through the foramen magnum and then come out of the jugular foramen with the rest of the accessory nerve. And the accessory nerve, of course, is your motor supply to your trapezius and your sternomastoid. And of course, we test the accessory nerve by asking the patient to shrug their shoulders or to turn the head to one side or the other and resist movement, because we're resisting then the activity of sternomastoid.